So I want to introduce Rajesh Malik. He's a vascular surgeon who works at New York Presbyterian at the Brooklyn campus or Brooklyn site, and he's going to be talking about compartment syndrome and the role of fasciotomy. Thanks.
Well, thank you. I'm going to try and drag this talk out a little bit because over the course of the years, I think we've all realized, I think that, as was mentioned before, if it's in your mind, chances are that you probably should be doing it. If you're talking about it, I always tell my residents in the OR, if we're talking about it, we should probably be doing it. If it's Friday, 5 p.m., we should probably be doing it. So, but just to give you a little bit of a history, it was first described in 1881 by Volkmann, and it was the clinical findings of myonecrosis and contracture due to prolonged muscle ischemia. And then over the course of many years, people started figuring things out that if you open up the fascia and you release that tension, you're able to perfuse, and that can give you better outcomes. Otherwise, you just end up with an amputation or essentially a non-functional limb. So what really happens is there's a condition in which increased pressure in one of the anatomic compartments results in insufficient blood supply to the tissue in that space. And here we're probably just talking about the lower extremities, but it really happens everywhere. You can have abdominal compartment syndrome. When we do ruptured AAAs or endovascular ruptured AAAs, probably not the open ones because obviously you're doing it open, but if you're doing an endovascular rupture, you have to think about these things. Are they going to develop an abdominal compartment syndrome? So any enclosed area, your arms, your legs, your butt, your thigh. I mean, we've all been there. We've all done fasciotomies in all these different areas. So it's a compartment perfusion pressure, and that's the mean arterial pressure minus the intercompartment pressure. So how do you diagnose? I mean, it's pretty impressive. I mean, you have excessive pain on passive movements. I mean, these patients will really they may just jump up, and you'll be like, wow, that's really strange that you have so much pain. But then you have to start thinking about what's going on, especially after all these. If you're doing something with ALI, I think that really has to be on the top of the list. If they call you, and that's happened to all of us as we learn. You'll do an acute limb ischemia case. You haven't done a fasciotomy. Patient's in the recovery room, and the patient's having a lot of pain. And sometimes we'll just be like, okay, well, just give them some pain medication. But you have to go and examine the patient and make sure that you're not really missing a compartment syndrome. So numbness is probably the first sign. It's the first toe web space due to the deep perineal nerve that you'll start and you'll actually go touch it and they'll be like, yeah, I can't feel anything. Absent distal pulses is a very late finding. You might be behind the 8 ball at that time. And look out for the 5 Ps, like paresthesia, which I said is the first sign, pain, pulse deficit, pallor. Sorry, that should be paralysis. I think maybe my daughter was typing when I was typing too. Compartment pressures, we get called to do these things. I'm telling you, the last time I used a Stryker needle was probably when I was a resident at NYU. That's probably 20 years ago. I don't even know if people still carry Stryker needles anymore. And even if they do, I don't know if most people probably don't even know how to use it. I mean, that's another issue, right? So in my mind, I think it's really becomes more of a clinical diagnosis. I think if you suspect it, it doesn't make sense to go looking for these things. You can also, if you really want to check you don't have a Stryker needle, what I've done in the past is kind of set up a CVP line. If that's in there in the ICU, for whatever reason, they're intubated, you can't get a physical exam, you could set up a CVP line and kind of try and make sure you zero it properly because otherwise you'll get some weird readings. And so normal 0 to 10, and I think if you're over 30 millimeters, then you should be concerned that there might be a compartment syndrome. So if you have compartment syndrome, that usually is an indication for fasciotomy. So if you have signs and symptoms, you should be doing it. Prophylactically, prolonged ischemia greater than 6 hours. We'll do these ALI cases, and we're in and out in 30 minutes, 45 minutes. Usually it turns out okay, but you have to be very vigilant. Trauma, crush injury, ligation of major vessel, or someone's been down for a while and there was a prolonged immobilization. I think you have to be very of that. These are patients where you may end up doing like a thigh fasciotomy or a buttock fasciotomy. It may not necessarily be like a lower leg, what you guys may see. That's probably the surgeons would see a lot of those. Extensive DVT, especially phlegmasia. So I've done a couple of, these are patients that you can't really treat or they have a contraindication to anticoagulation. With the newer devices, you can debulk some of them, but I still think that, you have to keep that actually works really well. So you actually can get them out of the trouble. Patients with altered mental status, if they're sedated, intubated, agitated, and you can't surely examine them or suspect them. So like I said, if you're thinking or talking about it, you should probably be doing it. Just a little bit of anatomy, and I ask the medical students this all the time. In the lower leg, the first slide is the thigh. Oh, we can go to the thigh. So thigh has the three compartments. Again, extremely rare to do a thigh compartment fasciotomy for acute leg ischemia. I think all the ones that I've really done have been due to trauma or crush injury or immobilization with the buttock and the thigh. The lower leg, there are 4 compartments, and I think it's important to get the deep posterior compartment. A lot of people forget that, and your CK is rising, and you're wondering what's going on. So you have to be worried that you have to kind of divide the soleus and get deep down and get that compartment opened up. Most of us do 2 incision fasciotomies. For the lower leg, you can do it in 1. I think a lot of the trauma guys like to do it in 1, but I think the fasciotomy you really should have good opening of the skin, because the skin itself can act like a compartment. So open the skin, open the fascia, just make a big incision. There's really not much downside to it. You can always close it up later or vac it. There are many options of dealing with that later on, but I think if you miss it, then it's going to be a problem. I've had to take patients back who have had incomplete fasciotomies done because the skin, there was a 2-centimeter incision in the skin, but your fascia is opened up for 20 centimeters. That doesn't work. So your skin and your fascial incision should be almost equal. And the other slide is just showing you a thigh fasciotomy, just going for the medial and the lateral locations, and then you can get into the posterior compartments. This is what it looks like. It's a nice incision. Mine are probably about this, so maybe slightly bigger, and you can see the muscle usually bulging. And I'll usually put an electrocautery on the muscle just to see if it's fasciculating or not, just to get an idea. Sometimes you can see the muscle is necrotic. It's very dusky and gray looking, and those are the patients that they were a little bit more far advanced when you got things treated. There's a guy that I just did in the ICU. So you can do it bedside too. I did this in the ICU over the summer, just a bedside fasciotomy on an intubated patient. He was found down, so he was immobile, developed phlegmasia, and ended up needing fasciotomies. So my take-home message is basically, if you are concerned, you should be doing it. I don't think there's much of a downside doing a fasciotomy, but I think missing a compartment syndrome can really be disastrous for the patient. Thanks.